In our very first episode of the Equity Lens, we spoke about equity in patient and public involvement. And because this theme keeps coming up, we thought it would be good to explore this a bit further. Just to see, how do we know we are doing engagement well, and how can we evidence this? Hi, this is Katalin, and today I'm talking to Dr. Kirstie Coxon, a reader in maternity care at the University of Central Lancashire. So hello, Kirstie.
Hi, thank you for inviting me to the podcast. Really interested in the topic. It's very close to my heart.
So I know that by background you're a midwife, a nurse. Can you please tell us a little bit about your research work?
I'm a maternity care researcher, and we have been really interested in public involvement in maternity research for a long time. I think it's one of the areas where there's been sort of real development of involvement since the 1970s, really. My own research has been about how people make decisions within maternity care. And I started off looking at how people make decisions about where they want to give birth. So how do women decide, shall I have a home birth? Shall I go to one of these nice birth centres I keep hearing about? Shall I be in a hospital? And I was looking at how people make those decisions, but also the extent to which they feel they can make those decisions. And so I involved service users in that work from the beginning. That was my PhD work. So I had a group of women and partners actually who helped me think about the question, how to recruit people, how to retain people, because I had quite long-term recruitment. People had interviews in pregnancy, at the end of pregnancy, and then postnatal. It's quite burdensome, we'd now say, on them as participants. So it was about, how do I make that work for you? How can I be unintrusive as possible? And also really helped me have understanding of the fact that some people didn't think this is a question of interest to them. And that's always interesting from a research perspective, when you really care about something and people think, oh, well, why would I even think about it? I'll do whatever the midwife tells me. I'll do whatever the doctor tells me. And we're thinking that it's our role to encourage people to make decisions. So I think it's kind of started there for me. And since then, I've carried on doing some work around particularly birth-based decision-making. I did some participatory research to develop infographics, so what we call icon arrays, where you've got little numbers translated into pictures to help communicate findings from research. And I did some research with NCT, with one of the big London hospital trusts, and actually with a clinical commissioning group, as they were then known, in Southampton, to involve lots of stakeholders in developing these infographics. So that's been a bit about my background, and carried on working in that sort of area, looking at how services are delivered, but also worked on other people's projects, looking at different interventions.
Because of your great experience with patient and public involvement, you can help us understand how this can be done well or better, maybe. So
I think, what are we doing, and how do we know we're doing it well, and how do we know that we're involving the right people? There's such good questions. I think, I have to start off by saying I'm a researcher, and I'm sitting here without any members of the public sort of talking alongside me. So, I've failed at the first hurdle, really, in lots of ways. So I have to apologise for that. How do we know we're doing it well? I think we know we're doing it better. I think we know that our aspirations are clearer, thinking about the history of public involvement. Somewhere between the 50s and the 70s, people wanting a bit more involvement in their healthcare in general. And sometimes that was quite political, because people felt excluded, particularly people that had disabilities. And from women's perspective, and here we are on International Women's Day, this is very much a political endeavour, because women felt very strongly that they should be involved in their healthcare, that they should have control over their bodies. And that discussion, which started, let's say, in the 70s, really, in sort of England and the States and across Europe too, is still going on. I think we thought we'd be somewhere really different by now. So I don't think we know we're doing it well yet, but we are still committed to doing it. And we see it happening as well in less resourced settings, where we are tending to export our ideas about healthcare and what works, but finding that they don't work if we don't involve communities. So I think the idea of public participation is not only local or regional or national, it's international and global, and spanning different resource settings. So I think the best we can do now is that we're doing it still. But thinking back to our more ARC perspective, the regional and national understanding, I do think we're still in the early stages, but we've got quite a long way since sort of mid-90s, when Involve was started, the NIHR, what's now NIHR Involve. So we've got sort of 20, 30 years experience of doing engagement in health and social care research. I think we've learned a fair amount along the way. I think we've got to a point where there is real recognition across funders and publishers and universities and care providers that it's a good thing, that it matters, that it's important. So actually reaching that consensus has been a lot of work, and that's great that we've done that. We've kind of normalised it as a thing that is part of our research process, at least in health and social care. And we're starting to really, I think, engage with interesting political questions about power in terms of who does research, who creates research questions, who makes decisions about funding. We've really started to understand that we can't address those power imbalances without working with members of the public, patients, service users, individuals, us, the citizens. But I think it's been quite a problematic journey, and there's lots of resource demands and costs and challenges. I think that those challenges are there for us as researchers, for our participants, for PPI members, and lots of them, I think, it really comes down to relationships, because dependent on us developing relationships that mature, that are trustful, that are reciprocal, where people generally do feel heard, even though there might become quite diverse views and we can't, address everyone's concerns or do what everyone wants, that people do feel that they're genuinely part of a process of decision making. So I think we see that developing well, and I think that's the current generation of engagement work is about being more participatory, looking at who's not at the table and thinking about the barriers to that.
And you were saying not just who we are involving, but how we are building those relationships. But how do we actually know that we are involving the right people?
It's a question about who we understand the right people to be. And I think what I've learned is that this changes from project to project. And it's about having that discussion at the start about who needs to be here for this project. So the right people are the people that have maybe a lived experience of the condition that we're talking about, that are comfortable talking about it, that have had preparation and training to attend a group sometimes, that have had barriers in terms of sensory problems or travel costs or access or childcare, that we've managed to address those barriers so that we can work collaboratively with people who have that lived experience. And also sometimes we overlook this a lot, the stakeholders and service providers, because when we're putting together research which is going to have an impact on practice and we neglect to involve the people who do the practice, generally are hiding to nothing, and the research doesn't get used, as we know. If you like, it's implementation science and what happens with our evidence after we've created it. And, we very often start teaching implementation science by saying we expect a 20-year lag between having good evidence and seeing a change in practice. That's not changing.
That feeds right into our previous episode on impact. That's an important point that you just made there. So one of the challenges is that we can't have every single type of experience or people represented every single time. What does that mean for our work? Where do we draw the line, and how do we circumvent or balance these limitations?
Yes, I think this comes up a lot when we start thinking about engagement, is representation. And I think part of the problem is the term representation, or not the problem, but I think part of what causes us to have to debate this is that some people think about representation in the quantitative research terms of there should be a representative of every group or perspective, or, every age group, every ethnicity group. And how far do we take that? Do we take it right across the whole population, or do we make it right for this particular project? But I think public engagement actually isn't intended to be representative in those terms. I think representation is more about being bespoke and thinking, well, for this project to work well, who needs to be sat at the table and sat at the table alongside us? And how many of them do there need to be? Because sometimes we do need to be careful to avoid tokenism and not to have, one person representing a huge patient group who then feels awfully responsible. So how do we make sure we manage the balance of who's sitting around the table so there's a good sort of mix of researchers and people who are representing people with a condition, people who look after people with conditions, service user organisations, and others who might have a particular voice or perspective, so that what you're doing is making sure that PPI engagement represents the project and problem that you're attempting to address. And I think as well, you can then look around and say, okay, who's missing here? Whose voice are we not hearing? And that happens a lot in maternity care. I was attending their webinar the other day about research in maternity care, and someone had done a large evidence synthesis about women's experience of induction of labour, so when labour is started artificially. And they'd found, say it's about 15 to 20 papers, qualitative papers, all about women's experience. And someone in the audience said, okay, how much of that was from people who are not from a white ethnic background. And the researchers said none of the studies involved had people from a white ethnic background. So although the studies have been conducted over the last sort of 15, 20 years, so this evidence since this, which should be a state of the art of what women's experiences, is missing a huge group. And not only are they missing a group, they're missing a group who we know have poorer experiences and poorer outcomes and are more likely to have problems for themselves or their babies. So we're missing an important group. So I think it's that kind of thinking, who's missing at this table? And when we are doing the research, it's no longer acceptable, I think, to proceed if we don't have those voices. Thankfully that we've had quite a lot of guidance. So we have the NHS Core 20+5 to help remind us of the groups that are suffering poorer outcomes in our health and social care systems. And the inclusion health guidance from the NHS also points us to some groups we might want to include. But that brings its own challenges and complexities, because some of those groups will find it harder to participate for really good reasons. An example of that is migrants and asylum seekers. Again, we want to work with maternity care very much because we know that they do have poorer outcomes. They have language challenges. They don't have good access to care. They're eligible for care, but don't always receive it. They might move around a lot, so it's difficult to give them continuity of care. But for someone who is currently an asylum seeker, it's not acceptable to expect them to pitch up at a meeting where everyone else is speaking a different language and they might really struggle to understand what's going on. So we have to think of other ways. And we've realised that, for groups such as migrants or asylum seekers, we need to engage with organisations actually that are advocating for them. And we need to build relationships with those organisations and not be exploitative, but find ways to talk to them and to ask if they can help us and ask what they need to support that engagement, and really start to work with, on the organisation level, with people that are comfortable, who may have a migrant and asylum seeking background, but are now able to advocate for that group and can go back to them and talk to them so that we have a broader perspective, but we don't make people uncomfortable by trying to bring them all to the same table. So I think that's where we are at the moment. We're having to have really detailed conversations about what it means to be representative and how we do that differently with different groups and sectors.
It sounds like a lot of it is all about reflection within your research team, and a lot of it is about building relationships, whether it's with public or patients, stakeholders, or organizations and charities. So we've now talked about how we know that we are involving the right people. Well, not a straightforward answer, I realize that. Let's say in an ideal world that we are doing it all right and we are involving and engaging people in a very equitable way. How do we demonstrate this to others?
That's something that I think we're all starting to really think hard about. And it's something that we haven't been doing well. People are struggling at the moment. I think there are lots of great examples of engagement in studies, and quite large studies and sort of good long-term engagement, but actually showing that it's equitable is a tough thing to do. So I think, again, we know that we want to do this, and we find some fairly straightforward approaches. So, we've been talking recently about writing an EDI form which gathers information so that we know at a glance who's present at a meeting. Or
sorry, what's an EDI form?
Equality, diversity and inclusion form. It's a form to collect data about those elements, those characteristics of people. And they're difficult to create because actually we're asking people for very personal information, and we're asking people to tell us how they see their ethnicity perhaps, or their affluence, or their language use, or their sensory impairments. And then we're also storing very sensitive personal data. So we have to really think about our systems and make that very robust and GDPR compliant, as well as telling people why we want to collect the data and why it matters that we know. So what seems like a relatively straightforward thing to do carries with it quite a big administrative and legal set of activities, which take time, which demand skills and understanding and are expensive. So, we have to bear all that in mind when we're trying to plan our engagement. So even a relatively straightforward way of gathering that data can be problematic. But there are quite a few tools now. So there's GRIP, GRIPP tool, which was produced by Sophie Staniszewska and some colleagues, King's and Coventry. And that's a reporting checklist to help you report your patient and public involvement in research. And it includes around 20 questions about all different elements. So this is to help researchers be better at saying what they do. Because in nearly every paper you read at the moment, it'll say, we had PPI engagement in this project, and that's it. It doesn't tell you what that meant, who it was, what they did, how often they met. So this is a reporting checklist to improve our formal reporting in papers or reports. But there's also a really nice toolkit produced by Queen Mary's University in London, and that's with Vast Impact, so Professor Mark Reed, which is about evaluation of engagement in research. And that's full of quite quick and acceptable measures. So if you were to hold a stakeholder engagement event, they've got a list of about 25 different ways of doing that evaluation, asking people to say who they are, what they thought about it, whether they felt involved and engaged. So I think that toolkit is so helpful as well, because you can build in activities to any meeting. And there's some very simple things like who turns up and who turns up the next time. Do we keep a note of who actually came to our co-investigator group or our stakeholder advisory group, and the extent to which we retained engagement and involvement? So I think we can use some quite quick and easy measures of who's there and who's still there, as well as building in these firm engagement and evaluation tools.
Can you talk a bit about methodology behind collecting that data? Are there any do's and don'ts? And how do we make sure that we increase our chances of getting the data that we need, but at the same time not putting all the burden on people who we are engaging?
It's a tough one. I think a lot of us are trying to think our way through this at the moment, because by the burden we mean we're asking people to share information with us and to sometimes complete forms and to do that regularly. And we know that it's the part of any sort of event or meeting or engagement attempt, the paperwork's often not done. We can produce the form but not find its returned to us. And I don't have the answers, to be honest. I think when we talk to people that are trying to do this, there are steps we can take. We can engage people in developing those forms. We can test the acceptability of those forms with people who are likely to be asked to fill them in. And we can think through how we frame them. So explain to people why we want the data, because I don't know about you, but I'm quite often asked to complete that set of data about my ethnicity and things. For me, it's quite non-controversial because I'm used to doing it. I understand why it's collected, and I don't feel worried that people are storing information about me, but I'm in a position of real privilege there because I'm UK based. They're not sensitive questions to me, or perhaps the sexuality ones are, but again, I don't feel uncomfortable answering them. But when we appreciate how threatening those questions can be for people that don't have that sense of security, then it's a different question altogether. And we can totally understand why people aren't willing. So how flexible can we be? Can we say to people, leave out these sections if you don't answer them? Is there a different way we can ask you? Tell us how you would describe yourself. And so I think there's ways we can do that. And there's also, I wonder to myself, are we asking the wrong questions? Because what we really want to know is, did you feel involved in this process? Did you feel heard? Did you feel listened to? Were you able to contribute? So maybe we ask, which to be fair are in those evaluation toolkits, there's other questions we can ask. So it's about thinking, what do we need to know about our engagement? And yes, we're being asked to find out data which helps us to show that we're being equitable and inclusive. But the bigger picture is we want those people to feel the will and do work with us, to feel that they're listened to, because that will help us carry on and we won't run the risk of losing relationships on the way.
So it sounds like we have made quite a good progress, but we still have a good way to go before we can do this well enough. In relation to this, what is your vision for the future?
That's quite a big question, isn't it? So,
yeah.
So I think I've got a vision for equitable PPI and health. And that's that we're no longer worrying about these questions, because it's completely normal to hear people from any background talk about how they got involved in research and what their involvement felt like to them, and that they felt that their involvement paid dividends and that they were listened to and their views were respected. So I think that's part of my vision, is that is so normal that we don't have to struggle with these trickier how to do it questions. And the second thought I had, which is a bit more niche, a bit more narrow, but it's that every scientific paper or report I read starts with a statement about why this question was important to those who use services and how they were engaged in research. Because I think we see an increase in including that, but it's not widespread. And very often papers are published I mean, I work as an associate editor for an international journal, and we publish papers where no one ever mentions engagement. I really wonder about that. We have a particular bar in the UK, and we're not sharing that bar more widely. That's my vision, that it's so normal that we don't have to worry about these questions, and that it's so widespread that the first thing you read in the paper is why it mattered.
Thank you so much for giving us some great insight into public involvement and engagement.
Well, thank you for talking with me. And I have to say, I've done a lot on the work of many other people here. So I'm hoping I'm bringing those tools and resources together, but I cannot claim any authorship for them. Not my work.
The most successful strategies are the ones that become obsolete because their objectives are the natural and usual way of doing things. That's Kirstie's vision for the future of equitable patient and public involvement and engagement, and we concur. Follow #ImplementEquity for more.